It's actually pretty staggering when you think about it.
Yeah.
Developmental dysplasia of the hip, or DDH, it's involved in almost a third of hip replacements for people under 60.
It's huge.
That's a massive, massive impact. And it's exactly what we're zeroing in on today. We had a listener request for an MSRA revision deep dive specifically on DDH, so we've pulled together the key info.
Absolutely, and it's crucial stuff. Basically, DDH means the hip joint just doesn't develop quite right in babies. It's, a spectrum, could be mild looseness, could be a complete dislocation.
Right.
So our aim here is to pull out the essentials for your revision, cover the definition, causes, risks, diagnosis, management, the whole picture, really.
Okay, let's do it. So first things first, let's nail down the fundamental. When we talk about DDH, what exactly are we describing?
Well, the key word is developmental. It's something that evolves. The hip joint, that's the socket, the acetabulum, and the ball, the femoral head, either doesn't form quite right or the ball isn't sitting properly in that socket. And what's really important, I think, is that a baby might seem fine at birth, but the dysplasia can actually develop later. It's a range, like I said. Mild dysplasia, the hip's stable, then instability. Then established dysplasia, which might mean subluxation, partial slip, or even full dislocation.
So it can change over time.
Exactly. For a quick memory jog, DDH, maybe think developing displacing hips. It's not static.
That definitely helps clarify it's not necessarily fully formed right at birth.
Okay, so what causes this? What actually kicks off this abnormal development? Is there one main cause?
Yeah, that's the tricky part. Often we just don't know a single clear reason. It's usually like a mix of factors.
Right.
Genetics is definitely in the mix. Family history ups the risk.
Yeah.
Breech presentation, that's a big one we see.
Okay.
And interestingly, maternal hormones during pregnancy are thought to play a role too. Then you've got mechanical stuff, maybe low amniotic fluid or just being a bit squished in the uterus affecting how the hip sits.
And maybe surprisingly, even things after birth, like how a baby is swaddled. If the legs are forced straight and together, that's been linked to it too.
So it sounds like multiple things coming together rather than like one specific trigger.
Exactly.
Talking about likelihood, who are the babies we should be most suspicious about? What are the main risk factors we need to keep in mind?
Yeah, this is super important clinically. The big ones are family history. If a parent or sibling had it, the risk increases. Firstborn babies seem more prone.
Okay.
Breech position, like we said, major red flag. And girls are much more likely, about 80% of cases.
80%, wow.
Yeah. Certain ethnicities, too, like Native American and Eastern European populations, seem to have higher rates. Then there are those maternal hormones and the mechanical factors in the womb we talked about.
Right.
Plus things like multiple pregnancy, being premature, certain neuromuscular conditions, cerebral palsy, for instance, restricted movement from low fluid oligohydramnios, and even sometimes babies who are head first but then swaddled really tightly can present later.
That's quite a list. Is there a way to maybe condense that for revision, make it stick?
Let's see. How about this? Firstborn females from native Eastern vermin. Multiple pregnancies are at risk due to mechanical hormones, restricted movement, and neuroconditions, sometimes presenting late despite cephalic swaddling.
Okay, yeah.
It kind of pulls in the main demographics and the pre- and post-birth factors, but definitely remember that female thing that should always make you think.
That mnemonic is pretty good, actually. It should help. So we know who's more at risk, but what's physically going wrong at the joint? The pathophysiology.
So in simple terms, the hip socket, the acetabulum, it just doesn't get deep enough. It's too shallow.
Wow.
Think of like trying to balance a golf ball on a saucer instead of in a proper tee.
Right, unstable.
Exactly.
Yeah.
Because it's shallow, the femoral head, the ball part isn't held securely. So it can move around too much. That's the instability. And in the more severe cases, it can pop right out dislocation. The exact sort of cellular stuff can vary a bit depending on the type of DDH, but the core issue is that mismatch. Ball and socket just don't fit well. That golf ball analogy really captures it, I think.
Yeah, that visual makes the mechanical problem very clear.
Yeah.
Okay, so if a baby shows signs that make us think DDH, what else could be going on? What differentials do we need to rule out?
Good question. Critical for avoiding mistakes. You've got to think about other hip problems. Hip joint infections, septic arthritis that can cause pain, limited movement. Some neuromuscular disorders can also affect how the hip presents, and even though they're usually in older kids, things like leg calvé-Perthes disease or a slipped capital femoral epiphysis, SCFE, you might keep them in the back of your mind if the presentation is a bit unusual for typical DDH.
Right.
So before you land on DDH, you need to actively exclude those other things. If a baby's limping, is it DDH? Or is it maybe an infection? That's the key question. Careful exam, maybe other tests.
Okay. Thorough assessment is key. Now, how common is DDH? What's the epidemiology look like?
Well, the numbers vary a bit, depends on who you study and how you diagnose it, but generally it's around 1 to 2 per 1,000 live births.
Okay. Relatively common then.
Yeah. And like we said, way more common in girls, and in those specific ethnic groups, Native American, Eastern European. Interestingly, the left hip seems to be affected more often than the right.
Any idea why?
Possibly related to the common fetal position in the womb, but yeah, left side's more common. And about 20% of cases affect both hips.
Bilateral. Okay.
And it's interesting how culture plays a role. Places where babies are carried with hips spread open and bent, they tend to have lower rates. Places using tight swaddling with straight legs, maybe higher rates.
Fascinating.
But the statistic that really stands out is that DDH affects maybe 1–3% of newborns overall, but it accounts for nearly 30%, 29% of hip replacements in people under 60.
Wow, that really drives home the long-term significance.
Absolutely. It really underscores why getting this right is so important.
Okay, so how does it actually show up? What are the clinical features we're looking for in an infant or maybe an older child?
Yeah, the signs change quite a bit with age. In infants, you're looking for instability, that sort of click or clunk you might feel when examining the hips. But caution here, not all clicks mean DDH.
Right, important point.
Limited hip abduction is a big one. If you can't easily spread the baby's bent legs apart beyond about 60 degrees when the hips are flexed at 90, that's a worry. You might also spot a difference in leg length, or maybe uneven skin folds on the thighs or bottom.
Okay, and older children.
Older kids, once they're walking, you might see a limp. Sometimes it's a waddling kind of gait, or an obvious leg length difference. Maybe they walk on their toes on one side, or just have a painless limp.
And screening.
Yep, screening is routine, part of the newborn check and the 6 to 8 week check. For infants under 3 months, we use specific tests, the Ortolani maneuver, trying to feel a clunk as a dislocated hip pops back in, and the Barlow test, seeing if you can gently dislocate a potentially unstable hip.
Right, Ortolani and Barlow.
Then there's the Galeazzi sign, looking at knee height when hips and knees are bent. Useful between about 3 and 6 months to spot a shorter thigh bone.
And if both hips are affected.
If it's bilateral dislocation, you might see that waddle, maybe an increased curve in the lower back hyperlordosis. But the Galeazzi sign might actually look normal then, because both sides are short. So you still need a really careful exam.
Okay, so for infant signs, maybe a quick reminder.
Let's see. Think. Clicking, limited abduction, uneven legs and folds, something like that.
That works. Helpful pointers. And interesting how the signs change. So what if the physical exam makes us suspicious? What investigations come next? Imaging.
Yeah, exam first, always. Then imaging helps confirm things and plan treatment. For young infants under about 4, maybe 4.5 months, ultrasound is best. Dynamic ultrasound.
Why dynamic?
Because you can see the hip moving in real time, check stability, see how well the socket is forming. Once the top of the thigh bone, the femoral head, starts to harden up ossify, which is usually around 4 to 6 months, then plain x-rays at the pelvis give us more useful information.
Makes sense.
Sometimes, for tricky cases or planning surgery, we might need CT or MRI scans, often need sedation for little ones, and occasionally arthrography injecting dye into the joint during surgery helps decide the best way to get the hip back in place.
Is ultrasound done for all babies?
No, not routinely for everyone. It's usually targeted for babies with risk factors or where the clinical exam raised concerns.
Right, a risk-based approach.
Okay.
Okay, so DDH is confirmed. What happens then? What are the treatments?
Management really depends on the child's age and how severe the DDH is. Broadly, non-surgical and surgical.
Okay.
For infants under 6 months, usually the first step is a Pavlik harness. It's a soft brace, keeps the hips bent and held outwards, flexion and abduction. This position helps the hip settle into the socket naturally and encourages proper development.
And timing matters.
Hugely. Early treatment is best. Ideally, before 6 to 8 weeks old, that gives the best results. The harness is adjustable as the baby grows.
What if it's very mild?
If it's really mild dysplasia and the hip feels stable on examination, sometimes we might just watch closely for a bit, maybe 6 weeks or so, see if it resolves on its own before starting the harness.
And if the harness doesn't work or it's diagnosed later?
Then surgery might be needed. Often it's a closed reduction. The surgeon carefully puts the hip back into the socket under anesthesia. They might also do a small cut to release tight muscles, like the adductors or psoas, called a tenotomy.
Okay.
For older children, the surgery can be more complex, maybe an open reduction where they actually open the hip joint. Sometimes, especially over 18-24 months, they might need to reshape the bone's pelvic or femoral osteotomies.
Sounds more involved.
It is. And unfortunately, the outcomes from surgery tend to be a bit less predictable in older kids. Higher risk of complications too, like a vascular necrosis, losing blood supply to the bone, or the hip dislocating again.
So follow-up is critical.
Absolutely essential. Close, regular follow-up, clinically and with x-rays, until everyone's happy the hip is stable and developing well.
It really sounds like the earlier the intervention, the better the outcome.
Right.
What's the general long-term prognosis?
Generally, it's very good. Especially with that early diagnosis and proper treatment, most kids end up with completely normal functional hips, no limitations.
That's good news.
Yeah. But, the long-term outlook can depend on how severe it was to start with, if there were any complications during treatment, and just how well the hip ended up forming.
And what if it's missed or treatment doesn't quite work? What are the potential complications?
Yeah, unfortunately, untreated DDH can cause real problems down the line. Ongoing hip instability, the joint can become deformed. Early onset arthritis is a big one, and just significant functional issues, pain, limping.
And treatment complications.
Even with treatment, especially surgery, things can happen. Redislocation, the hip might get stiff, bleeding during surgery. And that avascular necrosis we mentioned, that happens in maybe 5–15% of surgical cases, and it can cause long-term issues.
Right.
And remember that statistic DDH is a major reason for childhood disability and a big driver for those early hip replacements. Even if treatment seems okay initially, some people might develop degenerative joint disease or even low back pain later in life because of it.
Those are serious consequences. Really emphasizes the need for vigilance. Lastly, is there anything we can actually do to prevent DDH?
Well, since we don't always know the exact cause, prevention is tricky. But one area we can influence is swaddling practices.
Yes, you mentioned that.
Yeah. Educating parents on safe swaddling is key. We want the hips to be able to bend up and spread out naturally flexed and abducted. Avoid wrapping the legs tightly straight down and together. That forced position can really stress the developing hip.
Got it. Okay, so let's quickly summarize the key points from this deep dive on DDH for MSRA revision. We've covered the definition, developmental, spectrum of severity. The causes, often multifactorial. Key risk factors, remembering that mnemonic, perhaps.
Firstborn females. Yeah.
The pathophysiology, that shallow socket. The golf ball idea. Important differentials to rule out.
Like infection, yeah.
Epidemiology, how common it is. Those high-risk groups. The long-term impact stat. Clinical features, how they differ in infants versus older kids, the exam maneuvers.
Ortolani, Barlow, Galeazzi. Yep.
Investigations, ultrasound first, then x-ray usually. Management, Pavlik harness early on, then potential surgery. Prognosis generally good if caught early.
Definitely.
Complications if missed, or if treatment fails, arthritis, AVN. And finally, prevention through safe swaddling.
Exactly. The real take-home messages are early detection and appropriate management. They're absolutely crucial for good outcomes. So for your revision, make sure you know those key signs, the exam tests, and the basic treatment ladder based on age.
Right. Think about how a case might present in an exam scenario.
Yeah, a baby with risk factors, maybe specific findings. How would you diagnose and manage that initially?
Good advice. And on that note, if you want to dig deeper with more MSRA revision resources, you should definitely head over to pastthemsra.com.
And for free practice questions, flashcards, other learning materials, check out freemsra.com.
Brilliant. Thanks so much for taking this deep dive into developmental dysplasia of the hip with us. Thinking about how something like swaddling can influence hip development, it does make you wonder, doesn't it? What other aspects of early development might be subtly shaped by our environment or cultural habits? Something to think about.